Okay, let's talk about diabetes insipidus, DI. Okay, I think this was a really confusing topic between DI and SIDH, all the sodiums when I was in school. So I'm trying to make this super, super simple for you. Diabetes insipidus, IN, increased sodium levels in the blood. Okay, we are dry inside. Okay, we have diluted urine. Okay, we'll make that a theme throughout the presentation. So, as a general overview, diabetes insipidus, weird name, I know, we often refer to as just DI. Okay, this is either a deficiency of vasopressin from our brain or a non-response of our kidneys to the release of vasopressin. Okay, so this results in the inability of our renal tubules to concentrate our urine. So we're flowing like a river, y'all. We have polyuria and polydipsia because what does our body tell us to do? Drink more water if it feels dehydrated, okay? We have excessive thirst because our blood is concentrated. We are dry inside, die. So keeping it simple, it is a brain or a kidney problem. So we need to always consider this in hypernatremic patients, okay? So increased serum sodium. Why? We always ask that question, why? So if we don't have ADH, vasopressin, we are dry inside, DI. That simple. So vasopressin, which is also known as ADH, antidiuretic hormone. It's an important hormone for maintaining our fluid homeostasis. It's made in the hypothalamus. It's stored and released then in the posterior pituitary gland. Once it's released, it works on the distal tubule of the kidneys. So therefore, if we have low ADH, we are dry inside, DI. We have diluted urine. We don't concentrate our urine. Okay, so there's two causes, either nephrogenic, again, it's a kidney or a brain problem, nephrogenic DI, and this is our decreased kidney response to vasopressin, ADH. Then there's central DI, so this is also known as cranial or arginine vasopressin deficiency. A lot easier to say cranial, okay, cranial DI. This is a central problem. This is a primary vasopressin deficiency. This is a hypothalamic pituitary axis disorder. Okay, I'll say it again. It's a brain problem. So one of the things that our differential diagnosis, and we have this person who has excessive water intake, is going to be primary polydipsia. Okay, this person probably has normal ADH again, but they're having excessive water intake. Nephrogenic DI is most commonly inherited. It's X-linked, but we can also have an acquired disorder. And this is where we have a disorder or a drug that disrupts our medulla or our distal nephron, impairing our ability to concentrate our urine. So intrinsic kidney disease is one of these things, which include think about polycystic kidney disease, sickle cell nephropathy, pyelonephritis, hypercalcemia, people with Sjögren's syndrome, cancers, elderly people with decreased GFRs. Okay, we have acute kidney injuries in the hospital constantly, or chronic kidney disease. Okay, other drugs, lithium. I think I've mentioned this, and so many of these endocrine disorders, lithium really messes up a lot of our endocrine function, and that is another big red flag. Dexamethasone, so steroids, can cause nephrogenic DI. Dopamine, some antibiotics like ofloxacin, orlistat, amphotericin B. This can be due to an electrolyte imbalance. So perhaps we have high calcium, and with calcium flows water, low potassium states. And then there's idiopathic. So again, if somebody is elderly or sick, they come into the hospital and they just have DI from maybe now they have acute on chronic renal insufficiency. In terms of central DI, and these pictures, by the way, are from Zero to Finals. It's a great resource, and I have listed that on our last slide with a link. And anyway, so central GI can be inherited or acquired. And this form, actually, if it's inherited, it's more likely to be an autosomal dominant disease. It can be idiopathic. And this is a problem with our hypothalamus. So we have a decreased secretion of ADH for some reason. Our pituitary isn't working. And then think of acquired causes. And this is most often going to be a pituitary adenoma or a brain tumor. A head injury, mind you, if a head injury causes this, they're in big, big trouble because our pituitary is one of the most protected, I'll call it an organ, okay? It's a very protected structure in our brain, okay? It's right in the middle. So if they have a head injury, they're probably not doing very well, okay? There could be a brain malformation, maybe they were born with, or there's an AVM, an infection, so meningitis, encephalitis, or TB can be an an acquired cause. And then surgery, right? We did a pituitary resection for an adenoma. Maybe we did radiotherapy directed at the pituitary or another structure nearby. And then there can be an idiopathic form, i.e., we don't know. In terms of signs and symptoms, these are going to be related to large dilute urine. Think excessive loss of water. Think about how you feel when you're dehydrated. So your hallmark symptom is going to be polyuria, right? Normally, we have feedback mechanisms. We don't urinate all day long, okay? Polyuria, I'll say it 100 times, polyuria. You will see this again, polyuria, okay? These people are going to lose 3 to 20 liters per day. You can imagine what that's going to lead to. Some of these people are going to have polydipsia, and they're actually doing okay because they're responding to this dilute urine and they're drinking. They're listening to their thirst response. They have free access to water and they can drink. Okay, so they may present dehydrated. They may have some orthostatic hypotension. Obviously, if you're vasoplegic, you're dehydrated, you're going to stand up and feel dizzy. You're going to have neurologic symptoms if they're hypernatremic. Okay, if we have an increase in that sodium concentration because we're dry inside, we will have subsequent neuromuscular excitability. But there can be, when our sodium gets really high, confusion, and even so far, if these people don't have free access to water, think nursing home patients, confused patients, or somebody who's not mobile. They may even present in a coma, okay? They can also have symptoms of their underlying cause. So maybe they might have a headache if they have a brain tumor or AVM, etc. Again, extremes of age may present with severe dehydration and hypernatremia because they just can't access water. So how do we diagnose this? Again, picture's worth 1,000 words. So we need to suspect this in any patient that presents with polyuria. I'm peeing all the time. Infants may present just with dehydration if they have an inherited form, if the caregivers don't notice, or they may complain, man, I'm going through a diaper an hour. Is this normal, doc? Is this normal? PA, NP, to the provider, to their nurse, okay? Nurses, it's really important when you pick up on this. You may be the first one that does in the hospital, okay? In terms of laboratory work, we're going to first send off our basic serum electrolytes and osmolality. We often refer to this as osmos. Then we want to get a UA and measure electrolytes and osmos, okay? So in DI, our serum osmos are going to be high, right? Highly concentrated, blood because we have no water in it. Think about it that way, okay? And then our serum osmolality of our urine is going to be super low because we are dumping free water, right? So it's dilute. So we want to next confirm the diagnosis and determine the etiology. So is this a brain or a kidney issue? Well, the next step would be, let's deprive this person of water. If they're not already super deprived, right? If they're obviously stable enough. So we want to see if they can concentrate their urine in response to vasopressin, all right? So we try to limit any fluid for 8 hours, okay? No fluid or food. We do this all night long, right? We sleep, hopefully, most of us don't, but if we do overnight, NPO after midnight, all right? No fluid or food for 8 hours. So we're deprived. In the morning, hopefully, ideally, right? So we're not just starving our patients. We want to measure the urine osmolality. So get an early morning urine sample. And if our osmolality is under 300, it's low. If you have DI, right? You're still dumping urine. They might have gotten up multiple times during the night to urinate, but still that morning urine will be diluted. So we get that urine, we say, yeah, it's low. Then we will give them exogenous vasopressin, that's DDAVP, and we wait 8 hours and re-measure the urine osmos. Okay, so how does this test tell us if it is a brain or a kidney problem? Well, again, we've established that the morning urine has low osmolarity, right? So we established with the water deprivation test that they cannot concentrate the urine. Okay, so low urine osmos, whether it's kidney or cranial. Okay, well, here's the second part. Now we give them synthetic ADH, that stuff that the pituitary puts out. It's called DDAVP. So we administer that and then repeat another urine test. Now, if it's high, we now know that the kidneys can't be the problem, right? We gave them synthetic pituitary juice, the ADH, vasopressin, and they can now concentrate the urine. So this is a brain problem, right? Because the kidneys responded. Now, if the kidneys do not respond, this is a kidney problem, right? Because our brain can put out ADH all day long, but if the kidney cannot respond, we're going to continue to have low urine osmolality, okay? So keeping it simple, the kidneys are lower than the brain. That's how I think of it. So if the kidneys stay low after ADH, so they're already low osmos and then low again, kidneys are lower than the brain, it's a kidney problem. Low. Okay? Now, if this is primary polydipsia, we are going to have high urine osmos from the start, right? We deprived them. They're causing their own urine. Dilution because they're drinking water way too much all day long. It's usually a psychogenic issue. Okay, so if we deprive them of water in the morning, we're going to have a high urine osmo because they really don't have a problem with their brain or their kidneys. This is psychogenic. So a high urine osmo in the morning automatically excludes DI. So we don't have to go on to the second step. We have our diagnosis, okay? Okay, so how do we treat this? As with most things, the underlying cause. This is a common theme in a lot of these endocrine disorders, right? We have to figure out why, and then we have to treat that. So in mild disease, honestly, we can utilize conservative treatment. If they have access to free water, let them drink. If we did brain surgery, oftentimes we just give them free access to water, and if the patient can compensate enough through the natural route, which is enteral always, then we allow them to drink. We do want to restrict dietary salt and protein, okay, because this is going to concentrate our blood, okay. This is going to cause we already have a salt issue, and we don't need to make it worse, okay. In central GI, again, we can let them drink. Oftentimes, we'll monitor them closely in the ICU and then to the floor. And many times, people can't keep up with the oral intake. We have to work. If you can't be drinking all day. So a lot of times we have to do synthetic ADH, and it's very easily administered in a nasal spray. Okay, with nephrogenic DI, we need to. Sometimes we can give a super high dose of desmopressin to make them respond. Otherwise, some diuretics can work, and then there are some NSAIDs that work. In terms of prognosis, if this is not identified very early in infants and they become severely dehydrated, this can lead to brain damage, intellectual disability. So this needs to be picked up on right away. Some of these inherited forms that are autosomal dominant may lead to delayed growth in children, but potentially all complications are preventable if these people have adequate access to water, intake of water, and we are keeping this in our mind as a diagnosis. Okay, so here's a summary of key points for you. Here are references with some great resources, and I hope you all have a good day.